Welcome back, everyone. Whoa, this is a strong microphone. Welcome back, everyone. Right. We're moving on to the next topic on incidental findings, and that is a discussion of the ethical management of incidental findings in the research context. And Christine Grady will begin our discussion for us. Christine?
Thank you. First, I want to recognize the other members of my working group, Nita Farhani and Nelson Michael. And Nelson isn't with us today because he has been deployed. And we also had wonderful help from the staff, Lizzie and Karen and Kate in particular, but lots of people that behind the scenes that I don't actually know. So there were a number of things that we came to agree upon. One is we recognized the increasing possibility in certain modalities used in research of uncovering things that are heretofore thought of as incidental. So in the increasing use of genetic sequencing and imaging, in increasing research with specimens, using those modalities, we recognize that it's not only possible to predict that incidental findings might arise, but some evidence might be available about the meaning or implications of those predictable findings. And that evidence, such evidence, will help inform an evaluation of the extent to which the incidental finding provides useful information of potential net benefit to participants, as opposed to, say, uncertain information or information that might cause unnecessary stress, unnecessary cost, or more burden than benefit. So based on the ethical principles that we have been highlighting in a number of other areas, we thought that researchers should develop a plan for managing what we called predictable incidental findings and for disclosing to participants those incidental findings that are known to be significant and actionable, and when relevant, analytically and clinically valid, or the equivalent of those things. This plan that the researchers should put together should be reviewed by an IRB and approved, and should be described to participants in the process of informed consent, including what type of incidental findings might be found, whether and how they will be disclosed, and how participants might opt out of receiving certain types of information. I think a couple of things that were really important about our discussion when we were thinking about this, we wanted to be sure that predictable is not synonymous with common, that there may be things that you might predictably find even if they're uncommon, but they could be serious and actionable and things that you would want to do something about. We also wanted to be sure, I think, that predictable is not synonymous with has to be disclosed. So there are things that we can predict that you'll find. There are lots of examples I could give. The researcher needs to have a plan and say which of those he or she will inform participants of. We debated, as the earlier group did, the extent to which participants might exercise the right not to know certain findings, and whether there might be circumstances in which researchers could or should override participant preferences not to know. And we debated, similarly, are there times when participants may want to know something that a researcher can or should decline to tell them? So those are the same questions that Dan raised earlier. I think they're slightly different in the research context than they are in the clinical context, and so we can come back to them. Another thing that we recognized, everybody's aware that the ACMG recently recommended that clinicians who are running large-scale genetic sequencing should look for and disclose a delineated set of variants that are sufficiently serious to the patients who have the sequencing done. Other groups, and there's been quite a number of really good literature, groups of people who have spent time thinking about the implications of incidental findings in research, and many of those groups have proposed approaches of trying to group incidental findings into categories. One category, findings that should be disclosed, another category, findings that might be disclosed, and another category, findings that ought not to be disclosed, or some other way of describing it, but bins like that. And several groups have come up with this kind of an idea. And the differences between the three groups are based on the confidence that one has in what the finding means and an evaluation of the net benefit of disclosing the finding to the participant. So we thought, as a working group, that it would be advisable for knowledgeable representative groups, including subject matter experts, but not limited to define, or try to, define is the right word, the types of incidental findings that might predictably arise using each of these research modalities. The group should assess the available evidence of their significance and actionability, and then develop lists that would guide researchers and IRBs regarding the kinds of findings that should, might, and should not be disclosed to the participants. We thought these lists ought to be evidence-based, accessible, and updated, and the group's representatives. And the groups might identify specific areas where additional research was needed to establish evidence of significance or actionability. We thought that having such kinds of lists or groupings would be very useful for researchers and sponsors as they're developing their plans for managing incidental findings, but also for IRBs and other oversight bodies who are reviewing the plans. And we did recognize as a group that this kind of categorization may be more difficult for the modality of testing biological specimens than it would be for sort of genetic sequencing, for example, only because the realm of possibilities for biological specimens is so broad. A third finding, the group recognized that research is different than clinical medicine or clinical care, in that the primary goal is the development of generalizable knowledge, and that research is there's a broad spectrum of types of research, and where there are differences in expertise, and that there are considerable costs and burdens that might be involved in looking for incidental findings. And so we concluded, and we proposed to the rest of the group, that researchers do not have a general duty to look for incidental findings. However, a researcher could adopt, with IRB approval, a plan that includes looking for selected findings, selected incidental findings, or predictable kinds of incidental findings. Now, after this morning's talk, I'm wondering if some of these uses of incidental findings need to be changed. We may need different language, as Eric suggested, because the predictable incidental findings are not the stumble upon kind. A fourth finding of our group was that even if a researcher has a very well thought out plan for things that might be predictable, and no affirmative duty to look for incidental findings, he or she still might encounter unanticipated incidental findings. And in this case, ethical obligations still apply. So in this case, we thought researchers should have a plan in place for this kind of possibility as well, and inform the prospective participants that such unanticipated findings could occur. And then we thought that the researcher who encounters such an unanticipated finding should assess its significance, and that to the extent needed, seek help or consultation from other experts in order to do that. And then if the finding is determined to be significant and actionable, the researcher should propose to the IRB or to another appropriate specialized oversight body, because some institutions have particular ones that look at incidental findings, an action or a plan to offer participants the option of learning about the incidental finding. So I think we have several questions for the group. One, just if you agree that it's a good idea for researchers to develop a plan for predictable findings, that the researchers should disclose incidental findings that are significant and actionable, that these plans ought to be described to prospective participants, that participants should be given, to the extent possible, and this is something to discuss further, the right to opt out of knowing, that expert groups should gather to recommend the kinds of findings that might, and that should not be disclosed in given certain diagnostic or research modalities, that the type of evidence needed to inform these recommendations, analytic validity, clinical validity, seriousness, actionability, are the right kinds of evidence. That researchers and sponsors do not have a general duty to look for things that are not the target of their research, but could specify in advance particular things that they want to look for that are outside their target. And that researchers are responsible for appropriate and professional responses to unanticipated findings, might or maybe usually would seek help in verifying or establishing the significance of those findings, and should propose a plan for informing participants and have that plan reviewed by the appropriate oversight body. So I want to just raise 3 other things that the group didn't discuss, but I've been thinking about since we've had our last discussion, and some of them were based on this morning's discussion as well. One is, we talked about the issue of disclosing based on certain criteria like established evidence of validity and significance and actionability, but we didn't talk much about what, if anything, after disclosing we might be responsible for, and that question came up this morning. Another thing that we did not talk about as a group, but I think is very important, is this issue of filtering, because there are some references in the literature to things like, okay, one way to avoid the moral obligation of returning findings is to anonymize the data. Now that has some cost associated with it, so I don't know if we need to discuss that at all. And then the third thing that we did discuss a little bit, but I want to put in just a slightly different way to ask the question, is the limits, I guess, of the limits of informed consent, the role of the participant. And we did raise the question has been raised about, can a research participant say, I don't want to know any of these findings, regardless of how serious they are? Or can a research participant say, I want to know everything, regardless of how trivial it is? I noted that in some of the work that's been done primarily in the European groups, that they all say informed consent can or should be overridden because of professional obligations. But the discussion in research is just by its nature different than the discussion we had this morning in terms of the role of the physician. So I think these are things that we need to discuss right now. Nita, did I miss anything?
Thank you. I think that was great. I hope it's okay if I add a couple of thoughts on that. So first, Christine, I think you did an incredibly nice job of summarizing both what we discussed, but a lot of the issues that we have outstanding, but also thank you for just the privilege of working with you and Nelson on this. It was truly a wonderful experience in working through these issues. I agree with the idea that we have some of these issues that are outstanding coming from the clinical research side. I do want to focus on our research finding 2 for just a moment, because this is one that came about much later in the process for us. It sort of flowed out of our discussions of the other 3. And the way that we're discussing it right now isn't I think, where I ended up on it exactly in just the following way. So we felt like it would be incredibly helpful to have people who have knowledgeable expertise in the different modalities of research to define types of findings likely to arise, and to assess the evidence for, and then I'm going to say ... because this is an area where we defined a couple of things that we thought might be useful, a couple of metrics. We wanted to draw from existing work that's really been done in this area, but I think it would be useful for us to come up with some of the criteria by which we think follow that ... So we said potential significance and actionability, but I don't think what we were asking the groups to do were to develop recommendations about findings that should be returned, might be returned or not, but instead to provide something a little bit more like what Eric was talking about this morning, right? If there are secondary findings one can anticipate, being able to know what the primary, secondary findings are that one might anticipate in different modalities, and then be able to put those on a matrix to say, and these secondary findings that are likely to arise are clinically significant and actionable, for then researchers to be able to use that information to develop a plan. So rather than advising them as to what their plan should look like, to have useful data for them to be able to then rely upon in developing a plan. And so we didn't opine specifically about which one should be returned, shouldn't be returned, et cetera, and didn't, I don't think, come to the position of thinking that we wanted the industry groups to do so, but instead to provide meaningful criteria. And this aligns in a way, right, because things that are clinically significant and actionable are the ones that we would most likely expect the plan would have some way to address and to return. But we weren't asking, I don't think, exactly for that, but correct me if I'm wrong, Christine, if your understanding was different and what we were proposing the expertise weigh in on. And, so I put to the group, this one in particular would be really useful to have some additional discussion about, but also if there are additional metrics that would be particularly helpful in guiding researchers in developing their plan besides actionable and significant.
So Nelson is not available, so we'll begin with questions, and I'll recognize Barbara.
Thanks. Good report. I just want to be really clear on the no duty to look for incidental findings one. I mean, you made that as a flat statement, so you really decided that there isn't a duty. I mean, because what we heard in a lot of people that came and presented is that in a lot of studies they'll do a CAT scan of the brain, for instance, and don't have a graduate student read it for some very specific thing, and unless you had a radiologist overread it, you wouldn't know that there was a brain tumor or a malformation. You really decided that as long as they were careful to disclose to the research people that they either were or weren't looking for incidental findings, it was okay not to. Because I'm always have been a little uncomfortable with not at least saying there were a couple things that really should be looked for in every CAT scan of the head in a research study, but it would be a huge added cost. So I just wanted to be sure you'd actually really discussed it in that kind of a way.
I'll tell you what I understand we agreed to, and Nita may disagree. Let me use the example you used to play it out. So in that example, as I envision it, the researcher who's doing the study would have to have a plan for what would happen if there were some unusual findings on the image, let's say. The plan might include, verifying it with a clinical expert or something like that. But it would not require the researcher to say, in every case, we're going to do a clinical scan. Unless, for some reason, he or she wanted to, and then they could make the case and have that approved by the IRB. And I think the third sort of idea we had was first a plan for, there might be things that you find on all kinds of images that you want to do something about. But then there might be something that we didn't anticipate, and then we still have to do something about that as well. Does that comport with what you're?
I think that's exactly right, which is, 1, 2, and 3 really go together. So it's you have to have a plan. First and foremost, that's the most important thing. You need to have a plan for how you're going to deal with these things, and you need to communicate it to to research participants. But if you have a graduate student who is looking at the scan and who sees nothing other than exactly what's there, and your plan doesn't say that you're going to screen for secondary findings and put it through an additional clinical, scan, and your research assistant, your graduate student, is competent to be doing the type of research that they're actually doing, then there's no duty beyond that to look for and try to seek out additional incidental findings that you didn't stumble across.
So let me just on this, and I have Jim and Dan on the list, express a very narrow, but I think significant reservation / modification. So everything, all of the proposals are admirably, policy, practice-based proposals, which I think are, so this is my real agreement with them, which I think is in keeping with trying to minimize the ad hocness of the stumbling on an incidental finding. So you try to create as much both prior consent and understanding, and also as much rule-based regularity to what happens. And I think that's all to the better. My small but significant reservation is the narrow case that cannot be avoided entirely, which we discussed at the earlier meeting, of a competent researcher who's competent to see and analyze an incidental finding that was truly unexpected, and knowledge of it would be life-saving. And that example is no longer it's a researcher, and the researcher's general, professional obligation isn't to do it, but it falls in the category when it's really extreme and really competent of the duty to rescue if you can. And there's nothing here that suggests that just very simple, narrow moral duty, not legal duty, but moral duty, ethical duty, which legal doesn't follow from it, but ethical duty. You find something you didn't expect, no rule prepared you for it, and if you don't tell the person who is identified that she has this tumor that is treatable, this person's going to die, and there's nothing in here that says a researcher, just like any person, competent person, really in that case has an ethical duty to report the finding.
So maybe we should state it more explicitly, but we did in fact have that in there. I mean, that we stated, what we said was there should be a plan for serious and actionable secondary findings, or whatever they're going to be called, and you still have an obligation if you find something that you weren't expecting. The only thing that we built in there was if the person who finds it is not either competent to or confident in his or her judgment about how significant it is, then the plan should be to have a consultant. And then, but in the language, I think we want to be clear that if it's serious and actionable, and as Nita
So
said,
it's in
maybe
there?
absolutely,
Where-
should be disclosed.
Okay, it's in there. Okay, then that's,
Well, but one caveat of that is, so this is you're stumbling upon something that you really didn't expect to find. It is something that raises concern for you. You may or may not know yourself whether or not it's something concerning. You either assess it yourself, or if you aren't sure, you pass it along and seek consultation on that model. But your plan addresses this as well, right? So your plan says, if we come across a serious unexpected finding, here is how we will handle it so that the
I think
research
that's
participant
excellent.
understands
I think
it.
that's excellent.
Maybe just making that a little clearer, because it addresses my concern if you just make that a little clearer.
Okay.
One note on that, which is, and they can opt out, right? So that that's in that language as well, to say that it gives an option for the person to receive the results unless they have refused.
As long as that's doable, that's thoroughly ethically defensible and absolutely parallels our earlier discussion, taking account of the difference of a research realm. I have,
Can I respond to that just for,
sure,
sorry? Because I think the opt-out question is one that we had trouble agreeing on. I mean, I do think that there are a subset of cases in which I guess I feel pretty strongly that people shouldn't have the option of opting out.
And we just disagree on that, right?
let's come back to that to see if we can, as we did in the clinical context, parse it finely enough so we can agree, because we did get there in the clinical context. I suspect we might be able to get there in the research context as well if we parse the cases as finely as they have to be parsed in practice. But I really want to be able to get Dan, Barbara, and Jim. And I think Jim, you were the first, and then
yeah.
Dan, and then Barbara.
And mine's very quick because it was largely Barbara's question, but I want to make sure she and I understood the answer in the same way. In her particular case, where there's a graduate student looking at the data, is it fair then to say, well, as part of my plan, I cannot define any types of findings that are likely to arise? And that's that?
If it's true, but that's where modality-specific guidance would be really helpful, right? Because if you say, when you look at the brain, there's just no chance you stumble across anything different, right? I mean, that's not.
Yeah, I think, and I think you talked about this knowledgeable representative group. Is that what helps cover that situation where you tell some graduate student, I want you to look at this image, coordinate X and Y, and if it has a brightness above a certain threshold, it goes in this column, and if it doesn't, it goes in that column, next image.
We're not asking that they, for example, and I use the brain because that's one of the complicated areas. So if you have a graduate student who is trained to look in the amygdala, so just a small region of the brain, and you're asking them to just look for, changes in activation patterns in that particular region, and there's nothing else that, they see and that a competent researcher would see that would give them any pause and cause for.
That was the question, competent researcher. Is there an obligation to put together this knowledgeable representative group so that we ensure there are knowledgeable researchers involved in the plan, even if during the execution we are using technicians or
Well, this is a plan that we said should be approved by the IRB. This isn't just that the researchers develop it without any oversight, and it can't be, the graduate student simply lacks competence beyond knowing this thing. If it's something that arises regularly in the course of research in the specific area that they're looking at, it is something that the research, associate should be trained on as well.
So one of the reasons, Dan is going next, this is not a question, this is just trying to put these proposed recommendations in the larger context. One of the reasons it's so important to recommend what this subgroup is recommending about knowing ahead of time and informing research participants ahead of time is increasingly the line between research and clinical practice is very blurred. And even if it's clear in the researcher's mind, which it often is, that this is research, often participants who are getting their brain scanned or getting their genome mapped or you name it, in a research project, some of them have the expectation that if something abnormal is found, they'll know about it, and some of them don't. But if you don't actually take the time to have a plan and educate the participants, you have no right to assume that participants understand that they are just in a research project, because it's just those lines, particularly over the last decade, have become so intertwined, and there's so many research projects that quickly morph into clinical. And so I think these recommendations make that very clear, in a way that would not mislead, would minimize the misleading of research participants. Dan?
A rather small point about your fourth recommendation. If I heard you correctly, that after the investigator either characterizes the lesion himself or herself, and if not, defers on to somebody else, they would then go to the IRB to develop a plan to disclose. And if that's the case, it seems to me that that's sort of overkill, and that we might have the IRB approve a plan for disclosure and not, sort of involve them again at the point of disclosure. Is the latter what you were saying?
I
Okay.
think that's fair. I mean,
Okay.
the researcher,
Yeah.
has to have a plan to begin with that the IRB approves.
Right.
But we're envisioning that there's a, finding that's outside the realm of what they planned for, and that there might then, it might not need to be mandatory, but there might be a value in having an independent body look at it and say, yeah, this is something you should return, or this isn't, or this is how you should do it.
Yeah, I might suggest in something like that that the plan ought to be good enough that people be able to have the IRB approve their plan for disclosing those incidental findings, and they would certainly have to report it on whatever it is, quarterly basis or whatever, to the IRB of having found these sorts of findings. But I would hesitate to have, each time there's something incidental that's found, you have yet another level of IRB approval, just in the interest of bureaucratic parsimony, another
And
one of
I
our principles.
see if there are nods to that, because my one concern is that we not make this so burdensome a process for research that it really it unintentionally dramatically slows the research process down. And I think Dan's is a friendly amendment, that you don't have an obligation on every case to go back to an IRB.
Regulatory parsimony.
Regulatory parsimony, yes.
So I think that captures exactly the spirit of what we had intended. There's one piece that wasn't captured in what we said. So it was, we meant for this to be in the plan, right? So prior, you go to when you have your whole plan approved, the IRB signs off on your plan for unanticipated findings that you stumble across. But there are some close call cases where it would be useful to have an ethics consult. And it's not that it's mandated, but like Stanford, for example, has the ethics, board. It would be useful to be able to go to them and say, this is a closed case. Can you give us an opinion as to whether or not this should be returned? And that's what we were trying to capture by that second part, not to make it mandatory, but that it would be a useful thing for institutions to have to provide that kind of ethics consult.
Yeah, and
I
that might
see-
be that might be a research ethics consultation rather than the IRB under those circumstances.
Everybody's nodding to that, so I think that's a friendly and useful refinement. Good. Other,
Although, just to channel Nelson, I think he felt like it could be the IRB. Doesn't have to be, but it could be.
Right, just not in most institutions.
that's consistent with the friendly amendment that it could be. But when you make an IRB have to be, you not only burden the research, you burden the IRBs, which have huge loads. Other questions or comments from anybody, including anybody in the audience? Our audience has been the source of very good feedback. Okay. Karen Gallinari. Karen, who's a JD at the Montefiore Medical Center in Bronx, New York, the Director of Regulatory Affairs for Research and the co-chair of the Biobank Working Group of the Ethics Key Function Group of the 60 U.S. US CTSAs. Terrific, welcome. Does this commission plan to, or can it consider facilitating the commission of qualified economists to calculate the cost of and potential impact of implementing its recommendations on incidental findings in the research content as was just, and
I think it was proposed for the other.
it was just proposed for the other group, right, in the other context, right. So, good question. So, just to summarize it, is there an analogous proposal in the research context of calculating the cost of and potential impact of implementing recommendations on incidental findings? And I'll let the group respond, but just to preface it, I do think that these recommendations are, on the face of them, less costly than the recommendations in the clinical context. I mean, they're taking into account that the research, the goal of research primarily is not the same as the goal of clinical. But with that, I'm just prefacing an answer to the question from Christine or Nita. Nita, go ahead.
So we talked quite a bit about the impact on researchers and the impact on the research enterprise, and really sought to balance the research enterprise being able to progress with science and respect for individuals who are participating in the research, and felt that the primary additional burden that we're placing on researchers is one that they already, in many cases, undertake, which is to have a clear plan which communicates and addresses how they are going to think about and address incidental findings and return that information. So I don't think it warrants the same kind of economic analysis that the screening programs that arise in clinical settings do. And so we considered and didn't feel like it was the kind of burden that required and called for an economic analysis in this area. But certainly, I think it's always useful to invite other groups to undertake those types of economic analyses and to consider the cost and benefits of different programs.
Another way of thinking about it is, on the face of it, it seems like it would be more costly to ask for an economic analysis than it would be just to do this. I mean, because there is a cost to calling for economic analysis. They're not without, and this, on the face of it, doesn't seem to call for it because it's doing something, it's just adding clarity and some specificity to what researchers have to do anyway before they go to an IRB.
Although I would say that I think we're all in favor of more evidence that helps inform judgments. And one of the things we, I think, did specify was that if there are groups of experts, representative groups thinking about, what kinds of findings might be returned in a specific situation, that they should take into account evidence about the seriousness of the finding, the actionability, but also the sort of cost effectiveness of doing something about it. And those kinds of evidence need to be generated.
So Karen's question I think is, for me, productive of a companion question that just arose in my mind that I didn't think of earlier when I read this, which is, are there subsets of research for which this requirement of dealing with, of specifying incidental findings is so unlikely that even asking, is foolish? Or do you imagine for those kinds of research you just say incidental findings are not relevant to this research? In other words, every time you ask for another box to be checked or another line to be written, there ought to be some good evidence-based reason for doing that. And we have in mind here research in which there potentially are incidental findings. But there's a lot of research in which there isn't. And is this burdensome to that research, or is it just a piece of, it's just a check mark you have to put?
I think it could be, in some cases, just a check mark. So, for example, I'm just dreaming one up now. We do a research with biobanked specimens that are 30 years old, and you're looking at calcium levels. You're not going to expect that researcher to, even if they find an abnormal calcium level, to go back and tell the participants that donated their specimens 30 years ago. But at least the researcher has a question in their mind, is there anything that I might find that I should do something about? And that's part of the plan.
Dan and then Barbara.
Yeah, I was going to turn to one of Christine's additional questions, which I think were good. The first one about whether there's any responsibility beyond disclosure, I think is valuable. Partly to be able to try to set some limits, I think, again, on this, reasonable limits. I certainly don't think that there's a duty that the researcher has to provide the care. As much as many of us would be in favor of having research subject insurance, I'm not even sure that this should be covered by that, because it's not some harm that was caused by the research itself. It's only something that's uncovered. The most I might suggest would be at least a moral duty to help facilitate getting appropriate clinical care for the patient. But I think my guess would be that financial burden would lie with the insurance, et cetera, of the individual, and that people could perhaps facilitate obtaining the clinical care. As I'm saying this, I'm also thinking that perhaps there are these questions of resource poor. That would be in the U.S. Perhaps in a resource poor environment where the duties might be a little stronger than that. But I think in general, they ought to be much more circumscribed to informing and maybe helping to facilitate getting care, but not going to providing the care or underwriting the care.
Sure.
I think that's why I raised it. I think it's a really interesting question, and I think Beto asked Henry Richardson that question this morning, and he said, because his theory of ancillary care is you do something about it. You don't just disclose. But I think that opens a whole other can of worms, if you will, in terms of what we're supposed to be discussing. But it is also the question, what does disclosure entail? I think we've been envisioning it as giving people information and referring them to appropriate resources. But even that might be more than we're supposed to do. I think the question arises, should we be offering options of genetic counseling? I mean, there are a lot of questions that come with when you give people information, what else should you do? And I don't know the answer. I'm just raising the question.
So, we did discuss this. This is a hard issue, right? So you can imagine if you have really difficult news to share, what you should do with that, and whether or not there should be a counselor present or genetic counselor present or something else present. Good judgment and input from an ethical, review consult or something like that should be part of it. But given the myriad of different research contexts which we were imagining and the limitations of knowledge that many of those researchers are going to have in facilitating the next steps in care, it seemed like even imposing a moral obligation to facilitate the follow-up may not be appropriate in many different research settings. And so I think it's a consideration to take into account, which is, to the extent practicable within the knowledge set of the individual to facilitate care, that there is a moral obligation, given the nature of the relationship that's been developed with the research subject, to take steps when possible to facilitate the next steps. But it may be more like making sure that the person has something like a primary care physician or a contact to whom they can turn to be able to help them with the next steps, but a pretty limited duty at that, given again the myriad of context in which it arises.
Seems sensible. Barbara.
I wanted to go back to the two open questions that were the open questions in the clinical side, because I have very different answers in my head relative to research than I had relative to clinical. The one about if somebody says they don't want to know, would you override it? In the research setting, I think if it's life-threatening and treatable, I would say you would want to try to do that, ask them again and try to do it. But under any other circumstance, I wouldn't. I'd be very much, this is a research thing and they've signed permission for it the way they want it. And unless it's really treatable and life-threatening, I think that's it. And on the other side of it, if they want to know anything, whether it's minor or not, I don't think they have any research subject who signed a permit that says they aren't going to get anything except what they're going to get, that the permit says shouldn't get any other information. It's a research project, and that's different than the clinical kind of relationship that you have with your own physician.
May I?
Yes.
Do you have any concern, Barbara, about what we have to expect around the competency of the researcher when you do something like that? I mean, if you've got a psychology project using functional MRI, are we imagining that the team would have to have someone there that could make a judgment about what's life-threatening and actionable?
Well, I'm assuming that the plan would say that would be it. They would have it, or if they've identified it as that something like that might be an outcome of that kind of study, they would have some contingency for that. So I'm assuming that that's how they would pull out what is life-threatening, treatable kinds of things.
That's a really good example of why examples are so important. It's not enough to say, well, there are researchers who have no competency here, therefore we don't expect them to do anything. But it is enough to say that, as these proposals say, if you're conducting a certain kind of research, say psychological research, which has fMRIs, then you need you have researchers who really aren't competent in this area, of diagnosing. Right. You need a plan that informs the research participants of what they can expect by way of actionable findings. And there's a wide spectrum of plans that would be ethical, but at the extremes, which is saying, we're just not going to look at all because we hire researchers who are totally incompetent first-year students, that's unacceptable because that's just too cheap a kind of research to do. And the other extreme, which is we're going to do, full clinical scans and follow up with getting them clinical treatment. That's not research anymore. That's already, doing clinical work. So I think having plans within the range of reasonable, taking into account that there's always the Good Samaritan exception where you didn't, and you've put that in the plan. If we find something that we can competently diagnose as life-threatening, it could happen in this, we will inform and refer the person, if they don't have a physician, to the best of our knowledge who they should talk to. Something like that can work. But we do need those kinds of examples like Jim gave so we can see the spectrum that there is of research, from the research that is as far away from clinical likelihood of competence and so on, to the research that's pretty much interfacing with clinical practice.
You could foresee, even in a psychological study, finding somebody who's suicidal or depressed or something too, so that.
Absolutely, I wasn't trying to suggest that any psychology, that's what, but this is on the right track. I think it would be good in these proposals, in our discussion of them prior, to give some examples to suggest how relevant these proposals are. Yes, Nita.
I want to follow up on the first thing Barbara raised, which is Christine's open concern, just to propose a potential model to see if we can parse, similar to the clinical setting, whether there is a research difference. So I think for me, unlike the clinical setting, I wouldn't put an ethical obligation on the researcher to refuse a research subject's participation if they decline to have even serious adverse events reported to them. Although I would say that that is an option available to the research plan, which is they could say we will not accept individuals who will not receive it, but they don't have an ethical obligation to do so. So you have those options if you have given the research subject that option and they have refused to receive even clinically significant results, then I think you shouldn't return the results in those circumstances. But you could imagine if you're doing functional imaging or some sort of brain imaging where it is more likely that you'll end up with something that is a clinically significant, actionable, life-threatening kind of condition that you could exclude, and that would be permissible to exclude research subjects. But if you didn't exclude it, then you shouldn't return the research results. So that's a model that might be one that would parse it in ways that we could agree on.
I think just that parsing is consistent with the reasoning and the parsing we did in the clinical. So that's good. I have 3 different things. One is to make sure we go down Christine's added list on filtering. So we did the one, Dan brought up the 1. The 2 was filtering. What about, is it ethically legitimate to do what might be called the ethical end run, which is anonymize the data to avoid the responsibility, what Christine called the filtering. And I think that just fits into the just say no category, which is it's just an end run around what the ethical responsibility is, which is to have a plan, not to put blinders on so you don't need a plan. And the third...
Just to be careful, we don't throw out all anonymizing of data, because obviously
no,
there are good reasons to do that, right? But if the sole reason to do it is
Correct. That's exactly what I was directing it to. For when it isn't, when the reason to do it, the apparent and actual reason, you wouldn't do it otherwise except to avoid the ethical responsibility. And I think that was the one open one of Christine's. Now I have Margaret Ryan in neurology. Margaret, where are you? In the back. How can we keep a subject's research results from being put in a permanent personal medical record? If a normal, healthy control recruit reads the ICF and doesn't want research information placed in an EMR, electronic medical record, central clinical electronic medical record, through Epic, which is the one we use, they won't want to participate in research at all. Findings or no, they don't want information in their personal record. Right, Dan?
Yeah, I think it should be possible to do it, whether it's the policy of the institution. It sounds like you're suggesting there's some institutions that make it a policy to put all the research results into the clinical database. I think that would be problematic, and there ought to be ways of, protecting, producing protective firewalls between those sources of data. Yeah.
Margaret, does that answer your question? The idea is there actually should be a policy of not putting research data into personal clinical records. Good. Well, general policy, they're always, that's different. Okay, Judith Brooks from NIH. Judith, where are you? Should findings that are not actionable in the location where the study is conducted have the option to not disclose the findings to the subject?
International research.
can you, am I'm not exactly sure.
Maybe international research? Research in
Judith,
international
do you want
studies,
to
or-
just explain, do you have, yeah,
I think, we're talking about resource-poor settings. So if there's something that's discovered in a resource-poor setting that's not really actionable, that you didn't really expect to have happen, and the treatment or care isn't available, would you have an option of not
Okay.
disclosing that sort of information that would otherwise be something that could be treated in
In
a
an-
different setting?
in another setting? That's a tough one.
What she's saying is another category of not actionable.
Although
it
is
For
a-
that person, is that
It's
right?
an ethically different
Yeah.
category because it has an ethic, it has an injustice component
It
to
does
it.
indeed.
In other words, if this person were in another physical or economic setting, it would be actionable. But the research, so this arises most dramatically in in how you choose your research settings, right? And what you wouldn't want to do is a different kind of ethical end run, which is choose to do your research in a setting where you shouldn't you would be under no ethical obligation to report incidental findings because they're not actionable.
The standard of care is lower.
The standard of care is so low. I mean, this is not a hypothetical because we actually, in other contexts, deal with the ethics of where you do research. And this is a variant on that. Christine?
I think this is a really critical thing to put on the table because it seems to me this is why a plan is so important. That there might be times when you're going to do a specific modality, you're going to have a set of findings that you would expect to find using that modality, and you know that there's nothing that can be done with them in that setting. That might be a time when you can't justify doing it in that setting. I mean, I think it just depends on the study and why you're doing it. And it seems to me to have, at least in the direct answer to your question, Judy, to have a researcher say, well, I'm not going to tell them because it's not actionable here, is the wrong answer. But if there's a plan that says, we'll find X, Y, and Z, but here's what we're going to do about them, which might not include telling every person, or might include telling every person, I mean, that would be different to me.
Just one add on that, which is, oh, I'm sorry, Dan. It's just that's part of why that finding was not to say that when the different industry groups provide specific guidance, that it not be you should or should not return it. It's simply to provide metrics around the types of findings one might find so that they can be incorporated context-specific into a plan.
I was just sort of trying to think up an example to sort of fit this, and it might be something like studying cerebral malaria, which you're only going to do in a place where it's common, which would typically be a resource-poor area. And let's say you're using some sort of brain imaging as part of that study, and you find a brain tumor, right? I mean, that kind of question. I think that's, what you're going to do with that ought to be part of the plan. How you're going to actually accomplish that in those settings is a tricky issue. But
And I do
yeah.
think that it's an extension of our earlier, the filtering, which is if the only reason for doing it in that setting is so you could come up with a plan that you don't have to report those incidental findings, then that's unethical research. That plan should be rejected. If there are good reasons for doing the research in that setting, and there are a set of incidental findings that in another setting would be actionable, but in this setting there's really no reasonable way of making them actionable, then a different kind of plan would be potentially ethically legitimate in that setting. This is, what I just said is a matter of huge controversy as played out in the doing HIV research. And the one thing everybody agrees on is if the only reason for doing the research in a particular setting is to avoid certain ethical responsibilities, that is just unacceptable. And then there's the larger separate issue of what obligations you have in resource-poor areas for treatments that are hard to impossible to provide in those settings. I think we've reached the end of our time for this. And Christine wants to say one more thing, and I will gladly give her the microphone because of the wonderful work that she and her group did. So go ahead, you conclude this portion.
Thank you, Amy. I don't want to conclude. I just want to add one sentence to what Nita said earlier about, I agree that there are cases in which it's predictable that there'll be serious actionable findings, and if a person doesn't want them, they should be advised perhaps not to participate in certain kinds of research, and that there are other kinds of research cases where it would be okay for a person to say, I don't want any findings. But I don't want us to say that that's never overridable, because I think that there are circumstances that we can't anticipate and that participants can't anticipate, that for which we might want, with lots of consultation and stuff like that, to override somebody's opting out.
That is the end of this session, and we will take a break and reconvene at 2:15. Thank you very much.